Hi, I'm Tammy Tweed. Today we'll be discussing Chapter 9, Home Health and Related Community-Based Systems. Home health and community-based systems are changing rapidly due to increases in information technology. Within this chapter, we will be discussing three main concepts. The first is home health, palliative care and hospice, community-based public health, nurse-managed health centers, and other community-based practice models. The second is the electronic health records, the EHRs, and information systems used at community and home-based practice sites. And the last is the value of the clinical data and information that can be generated by these information systems. Core values of the community-based clinicians include patient-centered care and services that are of high quality, efficient, and cost-effective. The information systems began in the 1990s with billing systems and evolved to point-of-care solutions. The Outcome and Assessment Information Set, also known as the OASIS, the Hospice Item Set, also known as the HIS, and patient experience surveys are examples of home health and hospice standardized data sets. By using the standardized technologies, the strategy, it complements community-based core values. One of the standardized technologies is known as the Omaha system. This was developed by home health nurses and it's recognized by the American Nurse Association. Information systems are increasingly being used in the United States in the home health, and it's becoming more linked in the healthcare. This allows medical and health records to be transparent to increase efficiency. It's suggested that the home health is the optimal location for diverse health and nursing services. This includes patients' residences, including houses, apartments, dormitories, trailers, boarding houses, care homes, hospice houses, assisted living facilities, shelters, and even cars. Your schools, your churches, it could be community buildings or any other site. Home health combined with electronic health records aim to promote wellness and preventing disease, and to help take care of the sick and the dying. All these records are captured in the electronic health records so that they can be quantified, analyzed, and used to measure the outcomes of care. Home health uses a team-based approach, including nurses, social workers, physical and occupational therapists or therapy, speech language pathologists, and registered dietitians, home health aides, chaplains, physicians, and others. This is a team-based approach and interprofessional collaboration to address the family and the patient's needs. Within the community-based systems, the patient is referred to as client or customer, consumer, or even member. Home health and community-based systems have been around in history for many, many years. Before home health, you had end-of-life care was given by the women who lived in the homes, and at times even around the surrounding neighborhoods. Home health provided by formal caregivers originated in the 1800s and was based on the district nursing model developed by William Rathbone in England. The movement expanded rapidly into the United States, and 600 agencies by 1909. In 1893, Lillian Wald and Mary Brewster established the Henry Street Settlement House in New York City and developed a comprehensive program that was staffed by nurses and social workers. One of Wald's most impressive innovations was to convince the Metropolitan Life Insurance Company to include home visits as a benefit and to examine the cost effectiveness of care, which lasted until 1952. Public health departments began to expand during the early years of the 20th century. In the health department, the staff members were primarily nurses who focused on care of immigrants. They focused on milk banks for mothers and babies, also known as your WIC program now, communicable diseases, and environmental issues. They were concerned about consistent practice standards, the patient's record, and collection of statistics. Home health services became a major benefit when Medicare legislation was enacted in 1965 and resulted in significant changes nationally. The benefit was designed to provide intermittent, shorter visits with temporary lengths of stay to persons ages 65 or older. Health promotion and long-term services were not reimbursed. When a patient was admitted to home health services, the agency was required to develop a plan of care, obtain the signature of a physician, and follow additional regulations. Hospice care was introduced in the 1970s by Florence Wald, who created the hospice movement in the United States. In 1974, she established the Connecticut Hospice with interprofessional staff. After this, the concept of hospice grew from a commitment to provide compassionate and dignified care to people who were at the end of life stage. The program offered care in the comfort of the patient's home, with the main emphasis on the quality of life. Medicaid reimbursement for hospice began in 1980, and Medicare reimbursement began in 1983. Reimbursement determines many aspects of the hospice programs. Nurses that worked in home health were concerned about documentation, standardization, and accountability in addition to the practice. After this, in the coming years, many tools were created to aid in nursing and medical diagnosis. These include the International Classification of Diseases and the functional reach. These tools aid in practice and use standardized data sets for home health and for hospice. Now digging into the practice models, we will look at home health as defined in the book is the delivery of intermittent health-related services in patients' places of residence with the goal of promoting self-care and independence rather than institutionalization. As the hospital stays have become shorter, home health services have become more intense with post-operative care and with patients that have had surgery. The care in home health focuses on a safe transition back to the home following an episode of illness or exacerbation that required an inpatient or extended care facility. Interventions in home health include medication reconciliation, teaching and coaching to improve the ability of patients and families and caregivers to manage independently, coordination of care with other healthcare providers and community resources, and early detecting of decline or exacerbation. A few of the treatments and procedures that you will see in home health are the use of ventilators, renal hemodialysis, and IV therapy, including administration of antibiotics, chemotherapy, analgesia, TPA, and even blood products. In today's society, we have over 12,200 Medicare certified home health agencies. Medicare accounts for 45% of the total home health reimbursement. The other sources include Medicaid, at state and local governments, private pay, and private insurance companies. Home health sees over 12 million patients who ranged from infants to elders. Joint replacement and rehabilitation services and heart failure are top of the list for patients who are discharged from hospitals who go to home health for their care needs. This also includes even diabetes. So now we'll talk about palliative care and hospice. Hospice, the definition of that from our book, is the delivery of services by teams of interprofessional clinicians for those who have exhausted curative treatment measures. Hospice care is limited to patients with life expectancies of 6 months or less. It involves symptom management with the goal of providing as much comfort and dignity as possible at the end of life. Hospice includes bereavement, follow-up, or associated grief with the end of life after the patient's death. Palliative focuses on the quality of life for patients and their families facing the problem associated with life-threatening illness. It often begins once a cure is no longer possible and may be somewhat long-term. Its main focus is on comfort, quality of life, and end-of-life or advanced care planning. Both the hospice and the palliative care involves holistic care, which is an emphasis on dignity and being surrounded by comfort of your own home and your family, which is very important at those last times of your life. In 2013, there were approximately 5,800 hospice programs that cared for more than 1.5 million patients over an average stay of 72 days. As the largest payer, Medicare accounted for 87% of hospice expenditures in 2013. Looking into community-based public health, the basis of care in community-based public health is the individual, the family, and the whole community. Interventions would include health education and wellness campaigns, immunization clinics, screening events, parent-child health and safety, communicable disease, family planning, environmental health, substance use, sexually transmitted diseases, primary prevention, epidemiology and casualty, community assessment and public policy. There are currently 2,800 city, county, metropolitan district, and tribal health departments in the United States. Since 2008, health departments have lost 51,700 positions because of decreased budgets, layoffs, and attrition. Many of the nursing jobs have been lost because of lack of funding. This chapter has an emphasis on computerization to support these types of public health services that are provided to individuals and families within the community. As we move forward, we'll review the Nurse Managed Health Center, community health nurses, as well as advanced practice registered nurses, including clinical nurse specialists, NPs, certified nurse midwives. They provide care at urban and rural centers called Nurse Managed Health Centers. These centers work with the physicians and other interprofessional colleagues. More than 250 of these exist in the United States. Interventions would be clinical experiences for students and are located in underserved areas, primary care services, preventative care, chronic illness care, care for specific conditions such as obesity, and the target population. Their main focus is to target pregnant teens, fragile elders, low-income mothers and children, underinsured and uninsured. As far as other practice sites, you have your schools, your faith-based nurses, and occupational health nurses, as well as other clinicians. They all provide health care in non-institutionalized settings. With school nurses, they participate in classroom instruction, screen the school setting for safety hazards, like on your playgrounds and such. They provide medications in collaboration with parents and healthcare providers. They work with children who have special needs, monitor immunization status, provide and follow up on screening procedures. And with faith community nurses, they function as case managers when they help their parishioners to obtain needed healthcare services or food, shelter, or any other supplies. They provide educational and surveillance interventions for those who have chronic illnesses such as diabetes or cardiovascular disease. And then you have your occupational health nurses. They're employed by businesses with a high risk of injury or with an emphasis on health promotion and wellness such as smoking cessation, weight loss, and regular exercise. Community-based clinicians work with patients and their families over time. They embrace core values that influence their practice. They provide interprofessional collaboration. Their practice is based on people have rights and responsibilities, must know about their own health care, and must be partners in healthcare decisions. These themes are integrated into access, cost, quality, and IT. Within the home, the family and the patient are the ones in charge. Clinicians observe indicators and collect data about the patient's lifestyles, their resources, and their motivations. This is integrating into providing care. The clinicians can then identify patients' strengths and incorporate those strengths into the care process. The whole goal of the community-based practice setting is to provide patient-centered care and include patients, their families, and their caregivers in care planning and the delivery. Community setting nurses, they need skills that demonstrate dedication, flexibility, and independence. They develop and adopt care plans. The equipment are not readily available to the extent that they are in hospitals. Help and supplies must be available in the trunk of the car, cell phone, or in the electronic health record from the internet or pager request. The triple aim of healthcare. The triple aim for healthcare is to better care for individuals described by the 6 dimensions of healthcare performance, which is safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. To better health for populations through attacking the upstream causes of so much of our ill health, such as poor nutrition, physical inactivity, and substance abuse, and also to reduce per capita cost. Medicare and Medicaid. The funding regulations are a determinant of the type and length of home health and hospice services. Private insurance companies determine their own guidelines, but typically they follow Medicare's policies. Now moving forward into standardized data sets. This is a data processing workflow that converts the structure of different data sets into a common format. It deals with source and target systems. These data sets are required by Medicare, certified, and hospice settings. This concept began with the Residence Assessment Instrument, the RAI. This approach was adopted in response to a public outcry about the poor quality of care occurring in long-term and extended nursing facilities, and to the government's effort to bring visibility and transparency to care provided in these institutions. Over time, the use of the data sets have expanded from long-term care to home health, renal dialysis units, and other care settings. These sets collect patient characteristics, aggregation for analysis. The aggregated data often offer the opportunity for data-driven decision making related to care delivery and correlating payment systems to a predicted level of care needed by the patient. More types of the data sets are needed to achieve the care communication and coordination necessary to transform healthcare and achieve the triple aim of healthcare. The Outcome and Assessment Information Set, also known as the OASIS, is a standardized data set that home health agency clinicians complete with their patients. This is designed to determine payment and measure the quality of outcome of practice. It consists of 80 questions and response sets. Collection requirements vary according to specific times during the process of care, such as admission, transfer, resumption of care, follow-up, or discharge. In 2014, the U.S. Congress passed the Improving Medicare Post-Acute Care Transition Act, also known as the IMPACT.